So next up is my colleague and brother-in-arms, Joensi Passial of the CBCS. His paper assesses the long-term fiscal and demographic sustainability of Curaçao's healthcare system. Mr. Passial, the floor is yours.
Thank you very much, Jason. Good afternoon, everyone. Yes, so as a previous colleague of mine already indicated, the views presented here are of my own and don't necessarily reflect the views of the central bank. So, as already stated, my paper highlights the healthcare sustainability of the healthcare system in Curaçao. A healthcare system brings together all activities related to providing and organizing, financing, and regulating health services. Its main goal is to improve public health, meet public expectations, and ensure fairness in financial contributions. This study is motivated by global and local developments, where global healthcare costs are increasing faster than general inflation, government revenues, and key factors which drive the rising of an aging population, which is caused by decline in fertility rates and longer life expectancy. So, as population ages and health or disease burden increases, the demand for quality healthcare also increases. Along this path, this research seeks to explore the following themes. First, to examine the current state of the healthcare system in Curaçao, to analyze demographic, fiscal, and economic challenges in this relationship, and to present long-term expenditure projections. The general consensus is that public healthcare systems operate on the principle of solidarity. This means that everyone contributes to a shared pool of funds, which is then used to cover medical costs for those who need care. In this context, a public healthcare system is considered sustainable when its spending grows at the same rate or lower than the economy or tax revenues. In other words, sustainability depends on keeping the cost in balance with the available resource base. As already highlighted, from an accounting standpoint, healthcare system is sustainable when revenues are sufficient to cover expenditures. But looking beyond this point, from public health goods and services, sustainability can be viewed through three lenses. First, economic sustainability. That is when the cost of spending does not exceed the social benefits. From a second point, which is fiscal sustainability, that is when the system can be financed through public revenues without straining the budget. And thirdly, from a social sustainability perspective, when the system ensures equitable access to quality healthcare without sacrificing the long-term access. In reality, most national healthcare systems depend heavily on public funding, making sustainability as much of a political issue as an economic one. Governments must balance how much to spend on healthcare with growth of generating necessary revenues, which continues to put pressures on public financing. Now, let's take a look at the current system in Curaçao. The Basic Health Insurance Ordinance, the BVZ, took effect on February 1st, 2013. To address key challenges in Curaçao's healthcare system, it placed all government-run insurance schemes except the AVBZ to establish a unified healthcare system. Under the BVZ, all residents are entitled to standard healthcare packages managed by the SVB. Those who were privately insured before 2013 could keep their private insurance, but if those offered less protection than the BVZ, they were required to switch. Since 2015, the program also welcomed civil servants and retirees. By 2023, Curaçao's population reached 1,544 individuals, with which 91.3% were covered under the BVZ. This was around 140,000 people, bringing this insurance scheme close to universal coverage. The two key actors in the healthcare system of Curaçao is the government and the social insurance bank, SVB. They interact to manage the public healthcare system, where the government oversees healthcare system and shares the organizational and regulatory responsibilities with SVB. Among other, the SVB is financed by premium income, by government contribution, which subsidizes for people who are not able to contribute through premium income, through penalties and fines, and to patient contribution, which comes primarily from the AVBZ. Just to give some context, the AVBZ is, as I already mentioned, the basic insurance package, and the BVZ is a long-term specialized care package for those who are unable to work or need to be institutionalized for a longer period. So, we now take a look at how the systems are funded. So looking further, I would like to highlight some key points on the financial setup of the different systems. The BVZ, which in Dutch is de basisverzekeringsziektekosten, averaged from 2015 to 2023 an income-based premium around 278 million guilders, which is about 50%, and received income from government contributions around 273 million guilders, which is about 49%. The AVBZ, on the contrary, was funded primarily by income-based premiums, and over the same time horizon got 65 million guilders per year on average, and received patient contributions around 4 million per year. In addition, they also received government contributions, which started off at 7.5 million in 2016 and was later reduced to 2.5 million. This illustrates the financial dependency of both systems on income-based premiums with relatively modest or declining government contributions, especially relating to AVBZ. Now, I would like to present to you the following graphs, which provides a benchmark of Curaçao's position in relationship to other countries, other regions, and also indicate the development of our healthcare costs further. So, on the left graph, you will see the healthcare costs in Curaçao is rising faster than inflation and government revenues, aligning with global trends, as noted by one of the authors. On the right graph, in 2019, you can see that Curaçao's healthcare system amounted to 11.6% of GDP, which is significantly higher than Caribbean small states at 6.3%, middle-income countries at 5.3%, and low-income countries at 5%. Curaçao's healthcare spending is on pace with high-income countries, which average 12.5% of GDP. And the data underscores the fiscal pressures posed by healthcare costs and highlight the urgency of reforms to ensure long-term sustainability. On average, population growth has also shown some worrying trends. As you can see from the graph presented, on average, Curaçao's population increased by 0.2% from 2015 to 2023, but the overall trend seemed to reverse in 2023 when a new census was conducted. Diving further into the demographics of this population, we see that aging population emerges as a major concern. Research by Columbia indicates that the aging will significantly increase healthcare costs, particularly due to long-term care that is needed from the age of 65 onward. This creates additional financial pressures on the healthcare system. By 2050, Curaçao's share of population 65 and older is expected to reach 25%. At the same time, the old age population is expected to fall from 3.9 to 2.0, meaning that there are fewer working age people to support each older adult. The implication is clear. A shrinking tax base combined with rising healthcare demand will challenge long-term sustainability of the system. In assessing the economic and fiscal stressors, it can be noted that Curaçao's healthcare spending has been rising faster than economic growth between 2015 to 2021, where healthcare expenditure increased by an average of 2.5 per year, while nominal GDP by 1.4. Government contributions have not kept pace either. While healthcare costs rose by 2.5% annually, government funding increased by 1.6%, and total revenues grew more slowly at only 1.2% per year. This gap poses real risk. If spending continues to outpace growth, Curaçao could face difficulties in trading off, and crowding out could take place of other public services, increase in taxes, insurance premiums. There can be an introduction of out-of-pocket costs, or even seen a decline in overall care standards. When looking to the future, the literature identifies three main approaches for projecting long-term growth in healthcare spending. First is the microsimulation, which models individuals and produces highly detailed projections. It captures complex policy interaction and challenges that requires extensive data. The second is the micro-level modeling. The models are less data demanding and work well for short-term forecasting when structural trends are stable. Their simplified design limits their ability to detect turning points or assess how policies affect different groups. The third is a component-based approach, which breaks down the population and healthcare spending into specific groups as age, gender, healthcare status, or proximity to death. This method offers a balance, producing projections that are grounded in demographic realities while remaining practical to use. To summarize, the cohort-based approach provides a practical middle ground. It avoids the heavy data demands of microsimulation while offering more details than a broader macro model. This balance makes it well suited for long-term healthcare expenditure forecasts, specifically in countries facing demographic challenges. Now, given the available data, the most feasible option of our study was to employ the cohort-based approach model. It allows us to focus on age groups and population projections without requiring complex inputs that other models need. This approach is also consistent with international practices of institutions such as the Swiss Federal Statistical Office, the OECD, and the European Commission. Furthermore, this research employs two main data sources, the SVB, so the Social Insurance Bank, and the CBS, which is the National Statistical Office. So, following following well-established research, I applied a simplified version of their models to forecast Curaçao's healthcare spending from 2030 to 2050. The model estimates total cost by calculating the average medical expenditure per person in each age cohort and multiplying it by the projected population in that respective cohort for that respective year. I also developed a second equation of the model that adds the interaction between demographic changes, the average medical cost, and the projected inflation. Together, these projections give us a clear view of how healthcare expenditure may evolve over the next 2 decades and provides a basis for assessing the long-term sustainability of the system. Now, looking closer at the database, as already indicated, the projections are based on two key inputs, one being the healthcare expenditure patterns by age cohorts and the long-term demographic developments. Age-specific healthcare expenditure data is provided by the Social Insurance Bank, while demographic forecasts are derived from the Central Bureau of Statistics of Curaçao's 2015 publication, which projects the population projections from 2015 to 2050. SVB's healthcare expenditure data is drawn from various financing models, the fee for service, the capitation model, the lump sum budgeting model, each offering different level of detail. The average annual healthcare expenditure data per age cohort is used from 2015 to 2023, and the second average was employed, removing the COVID years to do the population projections. So now let's look at the results. For women, projected healthcare spending rise sharply by 2050, driven mainly by population aging, including the COVID years, causes only a small shift in the results, where the projected spending is expected to only rise by zero point 0.8 million. Under the demographic scenario, total expenditure increases by about 41%. That is an additional 126 million guilders, bringing the total cost of financing healthcare costs for women to 437 million guilders. When we also factor in price development, the increase is much larger. Spending rises by about 141% or 435 million and reaches in total an estimated 746 million guilders. This steep rise appears um, mostly in the older age cohorts, especially those above the age of 85, and are closely followed by those in the age category of 75 to 79 and 80 to 84. For men, a similar trend is followed, and controlling for the COVID pandemic years would actually decrease the healthcare cost by about 3 million. Under the demographic scenario alone, healthcare costs will rise about 43%, roughly 100 million. And under the price and demographic scenario, healthcare costs will rise by 144% to 313 million, bringing the total to 539 million. The male age cohort follows the same trend as the women. Bringing it all together, it means that the healthcare costs in Curaçao will rise about 42% from a demographics perspective alone, reaching a total of 752 million. And under a price and demographic scenario, the total healthcare cost will reach 1.2 billion guilders by 2050. In conclusion, the projections point to a steep rise in healthcare expenditure driven by demographic pressures as the population ages, costs grow, and government's ability to finance them creates significant fiscal risks. If spending continues on this path, the government may struggle to keep up with that. Some few recommendations, some policy areas to I'm out of time, but I can keep going. Thank you. Yes, some key policy areas to focus on are first to help reshape population dynamics. The secondly is to introduce measures to reduce the health-related age medical cost, and third is to strengthen the revenue base so the system can remain financially sustainable over the long run. And with this, I would like to thank you.
Thank you. Thank you very much, Juvency. Now, Ms. Naomi Francis, I didn't get the chance to introduce you before when you came to the table. My apologies. But please go ahead.
Good afternoon, everyone. Mr. Passial, I'd like to congratulate you on a well-written paper. This is a very interesting study, and I think you did a good job of summarizing the paper, so I think I will skip over the summary aspect of it. I found this paper to be rather interesting and fascinating, rather, particularly because it steers away from the regular economic analysis that we see, and because health economics is something that I myself have an interest in. You effectively encapsulated the exigency of the healthcare situation in Curaçao, and you allowed the reader to gain a solid understanding of the paper's motive. I appreciated your decision to analyze the concept of sustainability from multiple aspects, including demographic, economic, and fiscal assessments. It provided a broader understanding of sustainability, which is essential for this paper. Moreover, the marked differentiation between financial sustainability and economic sustainability offers clarity to the paper's context, and your analysis appears to be in alignment with global and regional trends that have been observed in the region. I have a few suggestions that could help in improving the paper. Within the healthcare section in Curaçao, you aim to provide an overview of the health system. And while the review provided quality context to the study, the magnitude of the expenditures relative to revenue may be lost on a reader due to the quotation of the figures in the local currency, which is the Caribbean guilder. And considering the role that the paper will play in literature, I would suggest that you consider quoting in a more universal currency, perhaps USD, which would make it easier for all readers to be able to understand, particularly for the benchmarking section, which would ensure a level playing field for comparison. Moreover, I think you could use a footnote to indicate the rationale for some of your variables used, particularly if you could clarify the rationale behind comparing healthcare expenditures to general inflation. Inflation in specific because it is influenced by several factors, so you may want to consider a comparison for health-related inflation as opposed to general inflation and ensure that it is quality adjusted in healthcare. This would be more effective and targeted for the context of the paper. Additionally, you could look at analyzing the revenue source that is used by the government to maintain the health system. A dissection of the healthcare spending at primary, secondary, and tertiary level would be beneficial in providing an understanding of the specific areas where funds are being utilized. Moreover, through microdata, the pressure points in the system could be identified to improve the understanding of the areas driving the increase in healthcare. The qualitative analysis of the variables movement provided a general understanding. However, some of the movements remain a bit unclear. So the inclusion of summary statistics and nominal tables providing a breakdown of data analyzed would be helpful to the reader. In going into the methodological evaluation, the method used in the paper appears to be inherently static in my perspective, and it suggests that you made very linear assumptions. It may not be the case, but that's what it presented. I would suggest that you try to adopt a more dynamic approach by incorporating, for example, scenario testing. So that would help in supporting the assessment of the population's evaluation over the forecasted period. For example, if you had a significant policy shift at T+5, how would that impact your projections? Furthermore, you seem to assume that the revenue source will continue to exhibit a trended behavior over the forecasted period. I think you could consider what if the cost grows at a slower pace due to efficiency gains, or if there's an improvement in care, how that would reduce the frequency of the service used. So the impact of these situations on the forecast would help improve the robustness of the estimates. Within the results and data section, you effectively highlighted the type of data utilized in the paper and the rationale. However, a few observations arose. The first one would be that there would be utility in you clarifying the type of cost included in the health insurance scheme data, as it is a bit unclear whether the indirect cost of healthcare administrative fees and insurance premiums were considered in the research data. It would be important in providing a wider view of what healthcare expenditure really covers, considering it was only mentioned that insurance and healthcare coverage scheme was used from the BBZ. So while I understand the rationale, I am of the opinion that this approach may possibly eliminate or understate costs for healthcare that could be incurred from other sectors. Additionally, when you consider the interlinkages between the health system and other systems of the economy, it is essential to understand the contribution of the different sectors to health expenditures. So inclusion of other data sources, such as the cost incurred under government-funded public health programs, which you would have mentioned in your introduction, along with their allocations, could provide a more comprehensive view of the health-related expenditure. You could consider variables such as the prevalence of the disease, service utilization, and unit costs within the analysis. Understanding the prevalence of certain diseases would help determine the probability of an increase or reoccurrence of the disease. In relation to migration, which you would have also mentioned in the paper, perhaps you could clarify as to whether low-cost healthcare practitioners are an option as a means of reducing the unit cost of labor. So teasing out the analysis on those variables would really help identify the pressure points driving the cost increase. In the same vein, you could look at addressing areas to improve efficiency, reduce production costs, and enhance relationships with suppliers. In relation to the econometric approach, have you considered the addition of a general equilibrium model to analyze sustainability? You could use, because your data is already micro data, you could use a well-grounded micro foundation to do this model, and it would provide a stronger picture of sustainability in general and on an individual level, and it would account for intersectoral linkages. It would also give a better assessment of government revenues and how the ability to meet payments will evolve. Further, you concluded the paper by suggesting that the government examined 3 specific areas. You could give a bit more detail as to how these areas could be explored and the intent behind some of the policies. Finally, based on some of the sources cited within the introduction, the IMF's recommendation that suggested easing fiscal pressures is necessary kind of indicates that the system is unsustainable. So you could consider extending the value added to the study by examining the root cause of the system's high cost, identifying areas within the system that require revision to address special social policies that may impact spending on health and may be a driver of elevated costs. So it would also be beneficial to include directed policy interventions. But I do want to reiterate before I end that your overall assessment of the system was very interesting, and you have a really good base. I think with those few suggestions, you could really get more in depth into what exactly is driving the cost, more than just seeing that the costs are moving towards being higher in the period 2030 to 2050. But overall, it was a really interesting paper, and I hope these comments help. Thank you.
Thank you for those comments, Ms. Harris. That doesn't leave us much time left for the floor. Juvency, would you like to touch on some of the comments and maybe make a few remarks before we wrap up this session?
Yes.
Yeah.
Thank you so much. Thank you so much for your great insights. I didn't explicitly say this in the presentation, but the paper is guided a lot by data availability and how that can be applied to get the projections that we wanted. So I do welcome the comments that you shared with me. I do think that I can explore how to apply these in the paper and hopefully get enough data in order to make those refinements to a final version of the paper. So thank you very much.
And thank you both. And I think with that, we will move on to our coffee break. Am I correct here, Jordan? All right, we'll take our break and we return back at, what do you recommend, 4 o'clock?